Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. NIK NIKAM, and today we are going to learn about aortic stenosis. I have been a cardiologist at the Texas Medical Center for more than 30 years, so let us begin. The objectives of this presentation include a definition of aortic stenosis, epidemiology, etiology, pathophysiology, history and physical examination, diagnostic tests, and management. Definition. The definition of aortic stenosis is obstruction of blood flow across the left ventricular outflow tract during left ventricular systole. So the obstruction could be right at the valvular level, the obstruction could be subvalvular, or sometimes the obstruction could be supravalvular. But in most cases, aortic stenosis is defined as the obstruction at the aortic valve level. Most of the aortic stenosis that we see are encountered in the adult population greater than 70 years, and in this population more than 48% of them are related to degenerative changes in the aortic leaflets, whereas in the younger population less than 70 years, 50% of the cases are related to the bicuspid aortic valve. This is an important distinction we want to keep in mind, and at the same time about 25% in both age groups are related to post-inflammatory changes such as rheumatic and other connective tissue diseases. Supravalvular. Supravalvular aortic stenosis is associated with Elfin phases, hypercalcemia, peripheral pulmonic stenosis, thrill palpable in the suprasternal notch or right but not the left carotid artery, and increase aortic second sound. So these are all the characteristics of supravalvular aortic stenosis, which in most cases is related to a supravalvular membrane. Subvalvular. Subvalvular aortic stenosis presents with a high Doppler velocity on outflow tract with normal aortic valve on echocardiogram. So if we encounter a significantly high velocity across the aortic valve, and if the aortic valves look pretty thin and normal, then we should always think about the possibility of subvalvular aortic stenosis. Frequent aortic regurgitation is found due to aortic valve jet. This may look like HOCM on echo with LAM. There are two subtypes, namely discrete 10%, secondary to subvalvular ridge, a little ridge, or it could be related to a tunnel in the outflow tract. Here is a normal looking aortic valve which is tri-leaflet with a Mercedes-Benz type sign, and the leaflet edges are pretty sharp and clean, smooth, and the leaflets are very thin and very flexible. In contrast to that, let's look at stenotic aortic valve, where the edges are ragged, they are thickened, and the whole leaflets are really heavily thickened, fibrotic, and calcified in degenerative aortic stenosis. There may be a lot of fibrosis and inflammatory nodules in patients with inflammatory aortic stenosis. Now let's look at some other differences in various types of aortic stenosis. In the congenital abnormality, generally the most common of which is the bicuspid aortic valve, we may see like a fish mouth opening of the aortic leaflet, aortic valve, along with the thickening of the edges and some degree of calcification. There may be also evidence of a fusion of two of the leaflets to form a bicuspid aortic valve. Whereas with rheumatic fever, there is a fusion of the commissures, and there is also evidence of a lot of fibrosis and inflammatory changes in the leaflets. In the age-related calcific aortic stenosis, we see a lot of thickening of the leaflets with heavy calcification and fibrosis, with again fusion of the leaflets, resulting in a very narrow hole in the center. Let's talk a little bit about bicuspid aortic valve. Bicuspid aortic valve accounts for 2/3 or between 50 to 60% of the patients with aortic stenosis in the adult population less than 70 years. 1/3 of the cases are in patients who are greater than 70 years of age. Severe aortic stenosis of bicuspid aortic valve is difficult to be differentiated from the normal tricuspid valve with degenerative aortic stenosis. The usual views of differentiation is a parasternal short axis view at the level of the great vessels in systole, where we can see the horizontal split opening of the bicuspid aortic valve. Parasternal long axis views show systolic doming of the leaflets into the aorta, giving a dome-like appearance, which can also be actually seen even in patients with degenerative aortic stenosis. Another important feature of a bicuspid aortic valve is the eccentric closure line noted on an M-mode echocardiography. However, a transesophageal echocardiogram can very clearly delineate the difference between a bicuspid aortic valve versus a degenerative changes resulting in aortic stenosis in a tricuspid aortic valve in the advanced age group. Pathophysiology. Because of the narrowing of the aortic valve opening, there is resistance to the flow of blood across the aortic valve. So we have an increased afterload. This increased afterload creates a gradient between the left ventricular cavity and the aorta. There is progressive increased thickness of the left ventricular cavity, resulting in left ventricular hypertrophy to compensate for the increased resistance and increased afterload. There is also decrease in systemic and coronary circulation because of the reduced cardiac output resulting from critically stenotic aortic valve. And as I mentioned, there is progressive hypertrophy of the left ventricle, leading to increased thickness of the left ventricle with reduced cavity size to compensate for the increased gradient across the aortic valve. The predominant symptoms of aortic stenosis include exertional dyspnea, chest pain, and syncope. These three symptoms are sort of hallmark of patients with aortic stenosis. Those patients who have critical aortic stenosis may manifest with any one of these symptoms, and they may have a direct relationship to the patient's underlying physiology and also prognosis. On physical examination, there are a lot of interesting findings that we can look for. There is a slow upstroke of the carotid pulse wave. The pulse volume is decreased because of the reduced cardiac output. We can also feel a left ventricular apical heave because of the concentric left ventricular hypertrophy. The S1 is normal because of the extremely stenotic and immobile aortic leaflets. The aortic second sound may be muffled or absent because of the calcific leaflets moving during systole. It can produce an ejection click. We may also have a late peaking ejection systolic murmur. In patients with left ventricular hypertrophy and non-compliant ventricle, because of the increased atrial contraction, we can hear an S4 gallop. So there are a lot of physical findings that can point towards aortic stenosis, and we should pay careful attention to palpation and auscultation. Again, an aortic systolic murmur can be conducted to the neck as a bruit, and it is always important to make it a point to listen to both sides of the neck, and if there is any evidence of significant bruit, we should also consider doing carotid duplex studies to make sure that we are not missing intrinsic carotid artery stenosis in the elderly population. Now let's talk about systolic murmur grading. The aortic stenosis murmur is graded from grade 1 to grade 6. The first 3 grades have no thrill, and if you feel a thrill, then it could be grade 4, 5 or 6. Grade 1 is barely audible, grade 2 is audible but is soft, grade 3 is a clear-cut ejection systolic murmur with a crescendo, decrescendo type of murmur. If we hear a grade 3 murmur and we can feel a thrill on palpation, it is considered grade 4 systolic murmur related to aortic stenosis. And if we can hear the murmur with the diaphragm slightly off the chest wall associated with a thrill, this is grade 5. And grade 6 is the loudest audible murmur with the diaphragm away from the chest wall along with a palpable thrill. So these are some of the characteristics of aortic stenosis murmur from grade 1 to grade 6. Based on this, you can evaluate the degree of stenosis of the aortic valve. Now let's look at some of the differences between aortic stenosis and hypertrophic cardiomyopathy. At the top we have the murmur of hypertrophic cardiomyopathy, and in the bottom we have the murmur of aortic stenosis. Let's start off under normal conditions while the patient is lying down. We have the ejection systolic murmur, and because of the prolonged ejection, the aortic second sound appears after the pulmonic sound, and the aortic second sound is accentuated in patients with hypertrophic cardiomyopathy. Whereas in patients with aortic stenosis involving the aortic leaflets, we do get the ejection systolic murmur and perhaps an ejection click, along with prolongation of the systolic phase of the left ventricle, but the aortic second sound is muffled or it may be absent in critical aortic stenosis. In patients with HOCM after Valsalva or standing, where there is decreased venous return, where there is decreased preload, the murmur becomes accentuated. Because hypertrophic cardiomyopathy is a dynamic obstruction, any reduction in the left ventricular cavity size leads to accentuation of systolic murmur in patients with HOCM. And it is exactly the opposite in patients with aortic stenosis. With decreased preload, there is decreased volume, and because of decreased volume, there is less amount of blood to be pumped across the aortic valve. That results in a reduction in the ejection systolic murmur along with prolongation of the systolic phase, just as we saw under normal condition. Now let's compare HOCM versus aortic stenosis after rapid squatting. After rapid squatting, the hemodynamic changes that we see include an increase in preload and an increase in afterload. Because of the increase in preload, the left ventricular cavity is filled with a lot more blood, and because of this increase in left ventricular size, reduces this dynamic obstruction in patients with hypertrophic cardiomyopathy. Thus the murmur becomes softer. Whereas in patients with aortic stenosis after rapid squatting, with increased venous return, there is more blood going across this significantly stenotic aortic valve. As a result, the murmur becomes accentuated along with the prolongation of the systolic phase with a soft S2. So these are some of the important hemodynamic changes that we need to be familiar in patients with hypertrophic cardiomyopathy as compared to aortic stenosis, because you may get 1 or 2 questions based on these changes in the murmurs in patients with HOCM or aortic stenosis related to hemodynamic maneuvers. Just to sort of give you a crash course on systolic and diastolic murmurs in cardiac patients, here we have the diamond-shaped ejection systolic murmur, which is seen in patients with aortic stenosis, HOCM, supravalvular, subvalvular aortic stenosis, and pulmonic stenosis. We have the hollow systolic murmur, which is seen in patients with mitral insufficiency. or tricuspid regurgitation, or patients with ventricular septal defect. We see an ejection click with a mid-systolic murmur, a soft mid-systolic murmur in patients with mitral valve prolapse, and the most diastolic murmurs related to aortic regurgitation or pulmonic regurgitation occur very early, right after the closure of the valves. That's why we get an early diastolic decrescendo murmurs. These are a very important terminologies that we need to keep in mind. Whereas mitral stenosis has an opening snap and a mid-diastolic rumbling with a pre-systolic accentuation. All right, that is a crash course on heart murmurs. Let's move on to the next part. Here's an arterial pulse in patient with a normal hemodynamic. We get a brisk upstroke with a sharp peak followed by a decrescendo. Then we have a dicrotic notch and a diastolic drop. Whereas in patients with discrete valvular stenosis, we have a tardy pulse where the upstroke is prolonged and the tip is also prolonged with a drop, and there is a less significant dicrotic notch. With supravalvular stenosis, the upstroke is generally normal, but the peak may be prolonged. Here's an electrocardiogram of a patient with an aortic stenosis, which basically shows left ventricular hypertrophy with the strain pattern. This is one of the most common electrocardiographic presentations in patients with aortic stenosis. Along with that, sometimes we can see left atrial enlargement, and there may also be evidence of left bundle branch block in some patients. Chest X-ray generally shows a significantly prominent left ventricular border with increase in cardiac shadow ratio compared to the chest wall, along with some evidence of pulmonary congestion if they have evidence of heart failure. All right, echocardiogram. Echocardiogram is a very important test in diagnosing aortic stenosis. Transthoracic echocardiogram combined with the transesophageal echocardiogram can provide us with the most information that we need in patients with aortic stenosis to make a clinical judgment as to whether they need one valve replacement, and if they do, whether they are candidates for TAVR or whether they need to undergo aortic valve replacement. Generally, we use the modified Bernoulli equation where the pressure change is equal to 4 times the velocity square, and using this one we can calculate the maximal instantaneous gradient and mean gradient across the aortic valve. Then we can calculate the aortic valve area based on the left ventricular outflow tract area, which is calculated by measuring the diameter of the left ventricular outflow tract, which I'm going to show you in the next picture, along with the left ventricular outflow tract velocity divided by the aortic valve velocity. We measure the left ventricular outflow tract, which is generally between 2 and 2.2 centimeters. Then we measure the gradient across the aortic valve. We also get the velocity below the aortic valve, and based on these 3 numbers we can calculate the aortic valve area. In addition to that, we can find a number of interesting features on echocardiogram. One includes thickening of the aortic leaflets, decreased mobility of the aortic leaflets, along with doming of the aortic leaflets. Here is an M mode showing there are increased echoes reflected from the aortic valve due to thickness and calcification, and there may be eccentric closure of the aortic valve in patients with bicuspid aortic valve, and also we may see very significantly decreased opening of the aortic leaflets. Along with that, we may see left atrial enlargement due to non-compliant left ventricle. We generally also encounter left ventricular hypertrophy. Here's an example of a patient with left ventricular hypertrophy with increased thickness of the interventricular septum and the posterior wall, along with some maybe left atrial enlargement with the doming of the aortic valve, as you can see here. We can also see diastolic dysfunction because of increased thickness. There may be evidence of pulmonary hypertension in patients with left heart failure. Along with aortic stenosis, we may also see some degree of aortic regurgitation. Based on the two-dimensional echocardiography, by taking a parasternal short axis view, we can actually measure the aortic valve area. Here's an example of an aortic valve velocity 5-chamber view. Here we have the left ventricle, here's the left atrium, and here we have the aorta, and the velocity is approximately 5 meters per second. So that gives a maximum peak velocity of 100 millimeters of mercury with a mean velocity of 70 millimeters of mercury. Based on this, along with the outflow tract diameter measurement, the valve area calculated here is 0.53 centimeters square, which indicates critical aortic stenosis. Along with aortic stenosis, we can also see some evidence of aortic regurgitation in these patients, and this may be an important point when we are thinking about aortic valve replacement versus percutaneous aortic valve procedures. Sometimes we may have to use tests such as dobutamine echocardiography in patients with moderate aortic stenosis who also have left ventricular dysfunction to predict the reversibility of left ventricular function before considering these patients for aortic valve replacement. So in other words, if we have a patient with left ventricular dysfunction and if they have moderate gradient, say like 30 or 40 or 50 millimeters of mercury, these patients can be subjected to dobutamine echocardiography to look for any evidence of reversibility in the left ventricular wall motion, which will help us to determine whether these patients will benefit after the aortic valve repair or replacement. How do we define the severity of aortic stenosis? The aortic valve area must be reduced to greater than 75% of its normal size before significant hemodynamic changes occur in circulation. The normal aortic valve area is anywhere between 2.5 to 3 centimeters square, and anytime the aortic valve area decreases to little more than 1.5 centimeters, it is considered mild aortic stenosis. If the aortic valve area is between 1 and 1.5, it is considered moderate aortic stenosis. If the aortic valve area is less than 1 centimeter square, it is considered severe, and if the aortic valve area is less than 0.7, it is considered critical aortic stenosis. With the degree of aortic stenosis, the gradient across the aortic valve also goes up. As you can see, in mild aortic stenosis, the gradient may be 25 to 30 millimeters of mercury, whereas in patients with critical aortic stenosis, the gradient could range anywhere from 60 to 100 millimeters of mercury. Which patient needs cardiac catheterization before transcutaneous aortic valve replacement or surgical replacement of the aortic valve? Cardiac catheterization is indicated for hemodynamic evaluation where there is a discrepancy between the clinical presentation and echocardiography. It is also indicated for young asymptomatic patients with non-calcific congenital aortic stenosis to define the severity of obstruction to left ventricular outflow tract. It is also indicated for patients in whom it is suspected that the obstruction to left ventricular outflow tract may not be at the aortic valve but rather in the sub or supravalvular regions. It is also indicated to evaluate the patient for coronary artery disease who are at increased risk for coronary artery disease. The complications related to aortic stenosis include atrial arrhythmias, the most frequent of which is atrial fibrillation, which can reduce the cardiac output by 20 to 30% because of the loss of atrial kick. Systemic embolization is seen in 10 to 25% of the patients, and it is very important to keep in mind that this systemic embolization can get complicated because it may be related to atrial fibrillation with the formation of clot in the left atrial appendage, or it may be related to calcified debris from the aortic valve, which may be causing the embolization. Congestion should be left heart failure can occur in patients with advanced aortic stenosis, especially after the development of atrial fibrillation. Pulmonary infarcts can also result because of severe heart failure. Hemoptysis secondary to ruptured bronchial veins or related to pulmonary edema may be seen in patients with aortic stenosis, which simply signifies the degree of stenosis and the complications related to heart failure. Endocarditis is again a complication which is seen more frequently in patients with deformed aortic valve, namely bicuspid aortic valve, and pulmonary infections are common due to the presence of heart failure in these patients. Prognosis. There is a prolonged latent period between the 4th decade up to 7th decade during which patients may be totally asymptomatic. They may have progressively increasing gradient across the aortic valve, however, they may be asymptomatic. But from the time these patients develop symptoms to the time of age is approximately 5 to 10 years. This is an extremely sad story as it relates to aortic stenosis, because by the time we diagnose these patients with aortic stenosis, their prognosis is already established. And that brings us to the question as when do we really intervene in patients with aortic stenosis? There are not many large studies to indicate that we should intervene in these patients before they develop symptoms, but when they do develop symptoms like exertional dyspnea, chest pain or syncope, then it is prudent to act upon as proactively as possible based on the degree of aortic stenosis. Let's look at some of the treatment options that are available. Of course, the medical treatment will be directed towards treating patients with left heart failure with digitalis, beta blockers, calcium channel blockers to control rates in atrial fibrillation, along with the endocarditis prophylaxis. The interventions include balloon valvuloplasty and valve replacement. And finally, we have surgical option which involves open heart surgery with valve replacement. Let's look at some of the pros and cons of percutaneous intervention versus surgical treatment for aortic stenosis. Before we go into the pros and cons of balloon valvuloplasty or valve replacement by intervention or by surgery, let's look at some of the class 1 indications for aortic valve intervention. Symptomatic patients with severe aortic stenosis, that is, we are talking about patients who have an aortic valve area of less than 0.6 centimeters square. Patients with severe aortic stenosis who also need to undergo coronary artery bypass surgery. Patients with severe aortic stenosis undergoing surgery on the aorta, for example, for aortic aneurysm or other heart valves like mitral regurgitation, etc. Class 2A indications are for patients with moderate aortic stenosis undergoing coronary artery bypass surgery or surgery on aorta or other heart valves. Asymptomatic patients with severe aortic stenosis, left ventricular dysfunction with moderate aortic stenosis, or an abnormal response to exercise, such as hypotension or significant arrhythmias. Class 2B indications include asymptomatic patients with severe aortic stenosis who develop ventricular tachyarrhythmias or who have significant left ventricular hypertrophy with a left ventricular thickness of greater than 15 millimeters, or if the valve area is less than 0.6 centimeters square, even if they are asymptomatic. Of course, class 3, prevention of sudden death in asymptomatic patients with none of the above indications. That means there is no evidence that replacing the aortic valve in asymptomatic patients would prevent sudden death. Aortic valvotomy or TAVR and surgical valve replacement using mechanical or bioprosthetic. Here are a series of diagrams showing how percutaneous aortic valve replacement is accomplished, first a guide wire is passed through the aorta across the stenotic aortic valve into the left ventricular cavity. Through that, a balloon is placed at the aortic valve level and it is inflated. After the balloon is inflated and the aortic valve opening is increased, a prosthetic aortic valve is advanced through this catheter and placed in position. And once the prosthetic valve is in place, it is expanded, which plasters along this stenotic valve, and it acts like the new valve in place of the critically stenotic aortic valve. This will enable a significant improvement in cardiac output right after the placement of the valve, and this avoids an open heart surgery, so patients can recover much quicker. And this is especially useful in patients with multiple comorbid conditions who are not ideal candidates for aortic valve replacement with a major open heart surgery. And here is a radiographic picture of a balloon in place across the aortic valve, and this dimple showing the location of the aortic valve. And here is a picture of the balloon across the stenotic aortic valve. Valve replacement, there are two types of valves that are currently available to be used in the aortic valve position, namely the animal tissue based or bioprosthetic valve. Then we have the mechanical valves which use tilting discs. Aortic valve replacement is indicated, as we said, in symptomatic patients with critical aortic stenosis. Aortic valve replacement improves survival in patients with normal as well as patients with depressed left ventricular function. The risk of surgery and prosthetic valve complications outweigh the benefits of preventing sudden death or prolonged survival in asymptomatic patients. In other words, aortic valve replacement for just prevention of sudden death in asymptomatic patient is a class 3 contraindication. Let's look at some of the differences between bioprosthetic valves versus mechanical valves. Durability. The bioprosthetic valves have a tendency to degenerate after 5 to 6 years. They may develop calcification and fibrosis and can lead to a need for a second valve replacement after 10 to 12 years. Whereas there is a very good long-term benefit by using a mechanical valve in the aortic valve position. Anticoagulants are needed only for the first 90 days in patients with bioprosthetic valves because they do not need long-term anticoagulation unless they have persistent atrial fibrillation or any other reasons for using anticoagulants other than the aortic valve itself. Whereas patients receiving mechanical valves need to be on anticoagulants lifetime. Survival of patients receiving bioprosthetic valve is 66%, whereas patients receiving mechanical aortic valve do much better, where the survival rate is 79%. There's also an inherent gradient built into these prosthetic valves. The gradient is more pronounced in patients with bioprosthetic valve because of the struts and the leaflets themselves, whereas with mechanical valve, because the disc tilt and open widely, the murmur gradient is less compared to bioprosthetic valves. Here is a survival post-surgical aortic valve replacement. As we can see, in 15 years, younger patients do much better compared to patients between 75 and 85 years. Prognosis. Once these patients develop symptoms, namely chest pain, exertional dyspnea, or syncope, the prognosis dramatically worsens, as I showed you in that prognosis graph. Thus, within 5 years of development of angina, approximately 50% of the patients will die unless they receive an aortic valve replacement. Prognosis is much worse in patients who develop syncope, where 50% survival rate is only 3 years. In patients who develop congestive heart failure, 50% of them die within the first 2 years unless the valve is replaced. Once these patients undergo valve replacement, they need a thorough follow-up with a cardiologist and cardiovascular surgeon. We should obtain echocardiography every 3 to 5 years in patients with mild residual stenosis. But if the patient has severe symptoms or evidence of heart failure, they must receive yearly echocardiography. Mitral stenosis and aortic stenosis is a mechanical problem, and medical therapy does not prevent progression. Again, medical therapy is and should be an integral part of postoperative management for patients with evidence of heart failure or cardiac arrhythmias such as atrial fibrillation or volume overload. So, ladies and gentlemen, this is a comprehensive review of aortic stenosis. I am Dr. NIK NIKAM, and please do subscribe to our YouTube channel, and we will see you next time. Thank you so much for your time.